So good evening all. Today we will move on to the next part of our first session. We have finished about the cardiac cycle and pulse, and today we will discuss about JVP and our blood pressure. Okay. So I think it will be good if we interact in between, and I will be asking some questions, and you can send messages. Okay. Yeah. So today's topic, we'll start with JVP. Today's topic will start with JVP. JVP is nothing but a oscillating blood column. So define JVP. JVP is defined as an oscillating blood column, where we'll see it in the right side internal jugular vein. We'll see it in the right side internal jugular vein, which will indirectly represent volume and pressure change in right side. Remember, it's only in the right side of heart. Generally, JVP will represent the volume and pressure changes in the right side of the heart, and it will change with different phases of cardiac cycle, and respiration. Okay. So this is all about JVP. JVP is nothing but an oscillating blood column which is measured in the right side internal jugular vein, which will represent the volume and pressure changes in the right side of the heart, which will change with the various phases of cardiac cycle and respiration. So first question, why do we preserve right side IJV? So why right side IJV? Because this is in direct communication. Or straight line with right atrium. Yeah, good. Good officer. Hafizur Rahman. Yeah, good. With the right atrium. Okay. Why not left side IJV? One more point is that left side, it has to cross the mediastinal structure. It has to cross the mediastinal structure. So in case of any mediastinal structure enlargement, such as aortic or aneurysm, or in case of any lymph nodes in the mediastinum, it will obstruct the right side IJV and your left side IJV, and it will cause raised JVP. So that's why we preserve right side IJV, because it is in direct communication, and left side IJV has to cross your left side IJV has to cross the mediastinal structures. Okay. So why IJV? IJV is internal structure. Why IJV over EJV? EJV is a bit easier to see, but why we preserve IJV over EJV? Any idea? Okay, because your EJV has more valves in it. Yeah, good Subishka. So EJV has more valves in it. So also it is affected by the EJV is affected by the facial planes. So when you flex your neck or extend your neck, the pressure may vary. So it is affected by the facial planes, and also it is affected by your sympathetic system. So during time of anxiety, your vein will get collapsed and may read as a false JVP. So that's why we preserve IJV over EJV. So one more favorite question of examiner: how will you differentiate between your carotid pulse and JVP? How to differentiate between carotid pulse, JVP? So carotid pulse, being an arterial thing, it is better felt. Like all other arterial pulse, it is better felt. JVP, like all other venous pulsation, it is better seen. Any arterial pulse cannot be obliterated by pressure. Okay. Any venous pulsation can be obliterated by pressure. Can be obliterated by pressure over neck. Okay. So carotid pulse, as we have already seen the waves in the pulse, just one positive wave. Just one positive wave per cardiac cycle. Whereas your JVP has two positive wave per cardiac cycle. That's it. One more with anatomical position. How can we differentiate with anatomical position? How can we differentiate with anatomical position? Yeah, your JVP is lateral to your sternal head of sternocleidomastoid muscle, whereas your JVP is here. Your carotid pulse is medial to your sternal head of sternocleidomastoid muscle, whereas your JVP is lateral. Okay. Moreover, your carotid pulse doesn't change. The carotid pulse doesn't change with position, like any other arterial pulse. It doesn't change with position, your respiration or your abdomen compression. Okay. Whereas this will change. We'll see it later. Okay. So next, how to measure your JVP. So I'll show you an image how to measure JVP. This is how you'll measure JVP. Make the patient comfortable and lie in a 45-degree position with a head and raised in the 45-degree position, and you look for make the patient neck towards left. Turn the neck towards left so that your right side of the neck is visible. Throat arch like tangentially. Look for topmost pulsation. So in this diagram, this is the topmost pulsation. So you need two scales. So one scale, this is kept parallel to ground level. You can see this is parallel to the ground level. It is parallel to the ground level at the point of uppermost visible pulsation. Okay. So another scale is perpendicular. It is perpendicular to first scale. We will keep parallel to the ground level, and second scale we will keep perpendicular to first scale. Okay. And you will read the marking in this scale. You will read the marking in the in your second scale. Okay. So normal JVP is around 0 to 3 centimeter. So you can with the help of this you will measure the central venous pressure. Okay. Central venous pressure is nothing but JVP plus 5 centimeter. Why 5 centimeter? Why this 5 centimeter? Can anyone answer why this 5 centimeter? Yeah, 5 centimeter is from the atrium. Your length of the your sternal notch. Your length of the sternal notch. This 5 centimeter. Okay. This 5 centimeter we have to add. Right atrium is 5 centimeter below your IJV. So we are adding this 5 centimeter, which it will give your central venous pressure. Okay. So the central venous pressure is measured in centimeter of water, which we can convert it into millimeter of mercury by dividing it with 1.36. Okay. So this is how we will measure JVP. So we have measured JVP. Then what are the things we will see? Things to be seen in JVP. Things to be seen in JVP. So JVP, as I told, will have two positive wave and two negative wave, and one deflection. One deflection is also positive deflection. Okay. So positive waves are your A wave and B wave. Okay. The negative waves are your X and Y. Since it is a negative wave, we will call it as a descent. And your positive deflection is nothing but your C waves. So we have 5 waves in JVP, your A, C, V, and your X and Y descent. Okay. So we see how all these waves are produced. We will see how all these waves are produced. The first thing is your A wave. So I will draw normal JVP and I will explain how all this happens. Okay. So we will mark. So listen carefully. JVP is a confusing thing. So listen carefully. So this is A wave. Okay. And this is your X descent. And this is your C wave, which is a positive deflection in X descent. And this is your V wave. This is your V wave. And this is your Y descent. So A wave means this part is your A wave. V wave means this part is your V wave. Okay. So why your A wave is produced? A wave is produced due to any idea A wave, why A wave is produced? Yeah, good. A wave is produced due to your atrial contraction. So we have seen cardiac cycle. What happens in the late part of the ventricular diastole? Your second rapid filling phase happens. So this is your heart. Okay, this is your heart. And this is right atrium. And this is your right ventricle. So during the late phase, what happens? Your late phase of a ventricular diastole, during second rapid filling phase, your atrium will contract. So since your atrium is contracting, it produces a positive pressure, and which will produce your A wave. And Y X descent in area, this will produce A wave. Y X descent in area. Okay, I'll tell you. So what happens? Not atrial relaxation. This poorly understood. I will tell you why how it happens. So X descent will correlate with the after what will happen after your ventricular diastole? Your ventricular systole will happen. So this will have correlate with your systole. Okay, your ventricular systole. What happens during ventricular systole? Your ventricle will contract. Okay, your ventricle will contract during your. This will go for contraction. So when it goes for contraction, what happens? It will pull your right atrial base. It will pull the right atrial base down. Okay. So this is your normal right atrium, and during the ventricular contraction, your right atrium is enlarged. So increased volume of your right atrium due to downward movement of floor of your right atrium. So once your volume is increased with the same amount of blood inside, your pressure will come down. The pressure will come down. So that will produce your X descent. But why positive deflection? But why there is a positive deflection in between this X descent? Yeah, bulging of tricuspid. Very good. So what happens? So this will produce your X descent. So why C wave? During this part of your ventricular contraction, I have said earlier, during your isovolumetric contraction, your pressure will rapidly increase. Your pressure will rapidly increase from 5 mm of mercury to the 80 mm of mercury during your early part of the systole. That is your isovolumetric contraction. The sudden increase in pressure, what it will do? It will push the leaflet of the tricuspid. This is your tricuspid valve. Push the leaflet of the tricuspid valve into right atrium, and which will produce a positive deflection, a transient positive deflection in your X descent. Okay. So next wave is your V wave. Why this V wave is produced? Any idea? Mitra, actually bulging of not mitral valve, because we are in our JEP we are dealing about only the right event in the right side heart, right of the heart. So mitral valve will not come inside this. Okay. So yeah, V wave is due to atrial filling. So what happens? Your atrium will receive blood. During atrial diastole, your atrium will receive the blood. So this will produce a positive wave. So because of the increase in pressure, it will produce a positive wave. Also see, normally your V wave will be of lesser amplitude compared to the A wave. The V wave will be of lesser amplitude compared to the A wave. So next, after this, Y descent. Why Y descent happens? Obviously due to opening of the tricuspid valve and your ventricular emptying. Okay. Sorry, atrial emptying. Right atrial emptying will produce, and then there will be a phase of diastasis, and then there will be a phase of your right atrial contraction, which will produce your A wave, and the cycle will go on. So let me write. So let me write it here. A wave is produced by your atrial contraction, and your X descent is produced by, write along with me, downward movement of floor of right atrium when your right ventricle contracts. This will increase the surface. This will increase your area of your right atrium, which will cause the reduced pressure, and the X descent happens. Okay. So why C wave happens? Because of your bulging of your tricuspid valve into right atrium during the early part of systole. Okay. So next, V wave, it is right atrial filling, and your Y descent is your right atrial emptying. So now moving towards the pathology part. Some pathology of clinical importance of JVP. So listen carefully. So what are the causes of raised JVP? Cause of raised JVP. தூக்கத்தில் சொல்லணும். Cause of raised JVP. We'll split it into cardiac and non-cardiac. So most common cause தூக்கத்தில் எழுப்பி சொல்லணும் right heart failure. So this is very important. So most important cause of raised JVP is your right heart failure. Okay. So some other causes are your constrictive pericarditis, your cardiac tamponade, and some have answered tricuspid stenosis. Though it is partially correct, we can add it. Tricuspid stenosis, your complete heart block. Complete heart block will have raised JVP. Okay. So non-cardiac cause, first one is pulmonary thromboembolism. So next one, pulmonary hypertension. So any other volume overload, any other organ failure, even liver failure, renal failure, even it can cause raised JVP. So volume overload states like liver failure or renal failure. Okay. Then your pregnancy. So these are other causes of raised JVP. So this is something which is raised JVP, and we will move on to particular wave. Particular wave, A wave. What are the clinical importance of A wave? A wave can be absent. A wave is absent in only one condition, that is, atrial fibrillation. Yeah, it is simple. To produce A wave, what it should happen? Your atrium should contract. But atrial fibrillation is nothing but an inefficient atrial contraction. Inefficient and rapid atrial contraction is nothing but atrial fibrillation. So in case of atrial fibrillation, your A wave will be absent. It is no-brainer. Okay. Then large A wave. Name some cause of large A wave. Yeah. To produce large A wave, it is simple. The physiology is simple. Your RA should contract against more resistance. Okay. Further, the pathology should be either in your tricuspid valve or a pathology should be in the RV pressure. Okay. So the pathology of tricuspid valve are your tricuspid stenosis or your tricuspid valve atresia. Okay. This will produce your large A wave. What are the causes? What are the condition causing high RV pressure? Right ventricular hypertrophy. Right ventricular hypertrophy such as your pulmonary hypertension and your pulmonary stenosis. Okay, yeah. Some answer right ventricular failure. Yes. Even right ventricular failure will have high RV pressure. Some cause of right ventricular failure are your pulmonary thromboembolism, active pulmonary embolism, and your right ventricular MI. Or your right ventricle should be collapsed. There is no right ventricle to contract. So collapsed right ventricle, where we will see collapsed right ventricle? Where we will see any collapsed any chamber? Tamponade. Yeah. In tamponade. In cardiac tamponade, because of the increased pressure inside the pericardial space, any part of your chamber will go for collapse. So these are the causes of large A wave. To produce large A wave, your RA should contract more against more resistance. So such causes are tricuspid stenosis and tricuspid atresia, or your RV pressure high such as pulmonary hypertension, pulmonary stenosis, pulmonary embolism, your RV wall MI, and your cardiac tamponade. Okay. So moving to the next part. Next pathology of A wave, your cannon A wave. Cannon A wave is nothing but very large shooting A waves. Very large shooting A waves. Yeah, good Mitra, good. For this, to produce this, what it should happen? Your right atrium should contract against your closed tricuspid valve, which means your RA, when your tricuspid valve will be closed, your RA, when your right ventricle is contracting simultaneously. Okay. So when it will be produced? So this is what we call it as AV dissociation. AV dissociation. So there is no connection between right atrium and ventricle, and your right atrium is going in its own way, and your right ventricle is going in its own way. So there is dissociation between atrium and ventricle, and you will call it as a AV dissociation. So causes junctional rhythm. What happens in sometimes your SA node will fail. SA node will fail. So your AV node will become pacemaker. AV node will become the pacemaker of your heart. So at that time, what happens? So this is your heart, and here is your AV node. Your AV node is producing the impulse. So it will stimulate the ventricle simultaneously and will stimulate atrium simultaneously. So that will be AV dissociation. The patient will have cannon A wave. So next cause, as Hafiz told, complete heart block. In complete heart block, the SA node will depolarize. Your SA node will depolarize your atrium, and your AV node or your Purkinje fiber, not AV node, your Purkinje fiber will depolarize your ventricle. So what happens? Not always. Sometimes there may be AV dissociation. There is a possibility of AV dissociation when both atrium and contract simultaneously. Okay. So some other cause, you can see it in VT, PSVT, or even ventricular ectopics. But these are rare. In exam, if they ask what are the causes of cannon A wave, you should tell junctional rhythm and complete heart block. Okay. So this is about A wave. Moving on to our next wave, your X descent. Okay. Yeah. X descent. So X descent can be because of two causes. Okay. Because of two causes. So sorry. Your X descent is because of your downward pulling of your floor of the right atrium during the AV during your right ventricle contraction, and your X descent. There may be two pathologies. Okay, one it is absent X descent, or that when you have a rapid or deep X descent. Okay, so why do they have a absent X descent happens? There is no fall. There is no fall. Right atrial pressure. Yeah, TR. Tricuspid. Why tricuspid? I will explain you. As I told you earlier, during X descent, what happens? The floor of the right atrium is pushed down. So there is increased space. Even with the increased space, if there is increased amount of blood inside the right atrium inside your right atrium compared normally, there will be no fall in pressure. Okay. There will be no fall in pressure. So most important cause of your absent excitation is tricuspid regurgitation. Very, very, very important. Is tricuspid regurgitation. So absent excitation is mainly due to your tricuspid regurgitation. Sometimes what happens? Instead of this blood, consider a clot, a blood clot, or a tumor inside this right atrium. This will also occupy space and will also not reduce the pressure inside the right atrium. So consider clot. Name one cause causing your right atrial or left atrial clot. Yeah, atrial fibrillation. Good episode. Your atrial fibrillation. Your atrial fibrillation will produce your clot or your atrial myxoma. Tumor inside the atrium. One of the most common tumor inside the atrium is your myxoma. Good. So next, your excision can be deep. For this to happen, your tricuspid ring or the floor of right atrium is pulled more downwards. Okay. For this to happen, why it should happen? Your RV is, your right ventricle is contracting very vigorously. So name some causes. No, not right ventricle hypertrophy, not necessarily. Your cardiac tamponade and your constrictive pericarditis. What happens in constrictive pericarditis or in your restrictive pericarditis or your restrictive cardiomyopathy? Your the ability of the heart to pump the blood inside your pulmonary artery is reduced. So to pump the blood inside the pulmonary artery, your heart has to contract more vigorously. Your right ventricle has to contract more vigorously, and this will produce your deep excision. So remember one point: constrictive pericarditis and your restrictive cardiomyopathy will have same JVP picture. So I need not tell every time constrictive pericarditis or restrictive cardiomyopathy. Whenever I tell constrictive pericarditis, it means also restrictive cardiomyopathy. Okay. So moving on to the next wave, your V wave. So V wave can be absent. Why V wave happens? Due to RA filling. So absent RA filling. Any idea? Absent RA filling, not thrombosis, because your SVC obstruction. When your SVC is obstructed, what happens? The blood will not come into right atrium, or severe hypovolemia. Even will have absent V wave. Then large V waves. Large V waves is due to increased filling. Okay, increased filling of your right atrium. So when will your name some causes? Not right ventricular failure. Yeah, tricuspid regurgitation. What happens in tricuspid regurgitation? During the systole, because of the leaky valve, blood will move from right ventricle to right atrium, and which will cause increased filling of right atrium. Then any other causes? Your ASD, your atrial septal defect. In atrial septal defect, normally before the shunting happens, normal blood will flow from left atrium to right atrium, left atrium into right atrium during this systole phase. Okay, during the systole phase, and that will cause increased filling. Then again any clot or your myxoma. Even this can mimic blood, and that will cause increased, which will cause large views. Okay. So next, one more condition: when your RA compliance is low. When your RA compliance is low, so your right atrium cannot expand to receive the blood. So one cause, as we all know, constrictive pericarditis and your tamponade. This will have large views. Okay, this will have large views. Next, wide descent. Wide descent. Okay, in wide descent we have three pathologies. Your rapid wide descent, slow wide descent, and your absent wide descent. Okay, absent wide descent. Why this rapid wide descent happens? Wide descent nothing but a RA empty. Okay, normally வேகமா empty ஆகணும்னா என்ன ஆகணும்? நிறைய blood இருக்கணும். So all these conditions which causes increased filling of right atrium will cause rapid wide descent. Your tricuspid regurgitation, your ASD, your clot, your myxoma. All the causes of large V waves will cause rapid wide descent. For slow wide descent to happen, it should empty slowly. Okay, so to empty slowly, what should happen? To empty slowly, what should happen? There should be obstruction. There should be obstruction, or there should be difficulty in emptying. Okay, that is nothing but your tricuspid stenosis, your tricuspid atresia, your right ventricular hypertrophy, your right ventricular failure, and your constrictive pericarditis. All these will have slow wide descent. All these will have slow wide descent. Indirectly, we can tell all the causes of large A waves. All the causes of large A waves will have your slow wide descent. And good Malavika, your absent wide descent is seen in one condition called as cardiac tamponade. And again, it is important. It is one of the most important MCQ for your NEET preparation. It's one of the most important MCQ for NEET preparation. Where absent wide descent is seen in constrictive pericarditis. Where absent wide descent is seen in constrictive pericarditis. And moving on to some next clinical points. Some of the questions asked in your model exams. Bernheim effect. Bernheim effect. Any idea what is Bernheim effect? Someone? Happy so? Mitra? Yeah, septal deviation. Septal deviation. You are partly correct. You are partly correct. Yeah. Actually, you can answer better. Mitra, you can answer better. You are partly correct. Where do the septum deviate? Towards right ventricle or towards the left ventricle? Yeah, towards right ventricle. Good. So we have already seen that all these waves of JVP are showing your tricuspid stenosis, your tricuspid regurgitation, your pulmonary stenosis, or your pulmonary regurgitation, your right ventricular failure. All these are right side events. All these are your right side events. In some left side events. Some left side events also. Left side events also will alter JVP. Name some left side events which is causing your septal deviation towards right ventricle. HOCM. Okay. Hyperobstructive cardiomyopathy. And your atrial stenosis. So what these two will happen, what these two will do is deviate septum to right side of ventricle. The septum of the ventricle will deviate the ventricular septum towards the right side of the heart. Your ventricular septum towards the right side of the heart. So what happens? It will produce the large A wave. Producing large A wave means that it is producing your slow Y descent. So this is called as Burnham effect. Left side even producing a alteration in the JVP. Burnham effect is nothing but a event in the left part of the heart is producing alteration in the JVP. Okay. So this is one favorite question for model examiners. Okay. For model aspirants, this is one question to be noted. So then, what is Lamb-CC sign? What is Lamb-CC sign of JVP? Yeah, CV. What happens in this is seen in tricuspid regurgitation. This is seen in tricuspid regurgitation. Actually, students, you are answering very well, but your answer is bit incomplete. So this is what makes a difference between a medal winner and a normal exam going student. Okay, your answer should be complete. In tricuspid regurgitation, as we all know, there is absent mixed descent. And there is a large V wave. So what happens to a JVP? It is like this. Okay, there is a C wave and there is a V wave and there is a rapid X descent. There is a rapid Y descent. Okay. So CV. So we'll get a CV wave and your rapid Y descent. So what this will do, will produce a pulsation during systole. It will produce a pulsation during systole. This will produce a pulsation during systole, a strong pulsation during systole, which is good enough to move your earlobe, your right side earlobe. So this is called as Lamb-CC sign. What happens in tricuspid regurgitation with each systole, because of the CV waves produced, your earlobe will move. So this is Lamb-CC sign. Okay, yeah, good, Mitra. And next, what is Friedrich sign? Yes, Friedrich sign. Any idea? Where is Friedrich sign seen? Yeah, in your constrictive pericarditis. What happens in constrictive pericarditis? There is large V wave and there is a rapid Y descent. There is a large V wave and there is a rapid Y descent. Why this happens? Because your RA and RV are very stiff that it cannot accommodate the blood vessel. So there is rapid rise and rapid fall in JVP. So this is nothing but Friedrich sign. So okay, the next sign, your Kussmaul sign, or this is also called as venous paradox. Any idea? Yeah. Normally, during inspiration, there is increased venous return because of your negative intrathoracic pressure. All the blood is sucked into the thorax. So normally during inspiration, your JVP should decrease. So paradoxical increase in JVP during inspiration is nothing but Kussmaul sign. Where are this Kussmaul sign seen? your constrictive pericarditis and your right ventricular failure. One important point is that this is not seen in tamponade. This is not seen in tamponade. This is again important. Your tamponade, this is again an entrance question. There is no Kussmaul sign in cardiac tamponade because there is no increased return. There is no increased return to heart. It will be normal. It will be normal as such during normal stage. Okay. So this is all about Kussmaul sign. Okay. Then one more point to complete JAP. Last point in JAP. Your hepatojugular reflex or your abdominojugular reflex. Okay. So first prerequisite for this to happen, your JVP should be normal. Okay, your JVP should be normal. Okay. This is normal physiology. What happens if you give a pressure? If you give a pressure for some 10 to 15 seconds in right hypochondrium with patient in 45-degree position, normally what happens? There is a transient rise. There is a transient rise in JVP. There is transient rise in JVP of up to 3 to 4 centimeters. Okay. This transient rate is for around 5 seconds for some 5 cardiac cycle. And then it will come to normal. So this is a normal phenomenon. This is a normal phenomenon. This is just a physiological phenomenon. So if this lasts for more than 5 seconds, this rise is lasting for more than 5 seconds, it is a sign. This is a sign of right ventricular failure. It is a sign of right ventricular failure. This is a early sign of right ventricular failure. This is a sign of early right ventricular failure. Remember, in late stage of right ventricular failure, your JAP will be already raised and there is no use in doing this hepatojugular reflex. Okay. To do this hepatojugular reflex, your JAP should be normal, and this is usually to diagnose your early right ventricular failure. Okay. So one more pathology can be there. There will be no rise. There will be absent hepatojugular reflex, or there is no rise. When it is seen, yeah, good. Your IVC obstruction. Yeah, Budd-Chiari syndrome. One cause of IVC obstruction is your Budd-Chiari. So yeah, good. And here we finish our JVP and we move on to the next topic, your blood pressure. Okay. So a class of another half an hour. So is JVP clear for all? Any doubts? JVP clear? These waves and why these waves are produced and the pathology of these waves. Is it clear? We have covered almost all part of the JVP. இதுக்கு மேல JVP ல இருந்து ஒரு கேள்வி வராது. If you be thorough with this. Okay. Good. We are moving on to the next part. So blood pressure. Define blood pressure. It's nothing but a pressure exerted by the moving blood. Okay. Pressure exerted by the moving blood on vessel wall unit area. Vessel wall in unit area. Your arterial wall. To be precise, pressure exerted by the moving blood on your arterial wall per unit area. This is JVP. This is defined as JVP. Okay. We have some pressures. Systolic BP. This is nothing but maximum BP attained in systole. Maximum BP attained in systole. So these definitions are just for some old-fashioned examiners. Just I will skip it through. Okay. Karan?
சார் சொல்லுங்க சார்.
Karan கேக்குதாப்பா?
சார் ஆடிபிள் சார்.
இது screen sharing stop ஆயிருக்கு போய்.
சரி இல்லை
Hello?
சார் ஒன் செகண்ட் சார் ஒன் செகண்ட் நான் ரெக்வஸ்ட் பண்ணேன் சார்
Yeah.
இப்போ தான் சார் ஆஃப் ஆச்சு.
Okay. Yeah, okay.
Okay.
Okay. Maximum BP attained during systole. Okay. This normally is around some 120. To be precise, it is 120 and it is almost around 100 to 130. Okay. So, it depends on, systolic BP depends on your cardiac output. Okay. Then diastolic BP, this is the minimum BP that is attained at your end of the systole. Minimum arterial pressure that is attained at the end of the systole is normally around 80. It is 60 to 80. We can have a range of 60 to 80, and it depends on peripheral vascular resistance. Okay. So next, pulse pressure. Pulse pressure is nothing but the difference between systolic BP and diastolic BP. Then mean arterial pressure. Mean arterial pressure is nothing but pulse pressure plus 1/3 of your systolic pressure. Pulse pressure plus 1/3 of your systolic pressure. Can you please tell me, இது இந்த நாள்ல எது இம்பார்ட்டன்ட் அப்படின்னு என்கிட்ட ஃபிசிஷியன்ட்ட கேட்டா, I will tell it is mean arterial pressure. Which one do I am worried about? If I am worried about systolic BP or diastolic BP or pulse pressure, எது clinically important அப்படின்னு if you ask a physician, any physician undoubtedly will tell mean arterial pressure. Why? Any idea why mean arterial pressure? Okay, because this mean arterial pressure is something which is going to decide on the perfusion to all organs. Perfusion to all organs. Okay, there is reduced mean arterial pressure. What it will happen? There is reduced perfusion, and the organ will go for damage. And the organ will go for damage. So this is important. Okay. So next, methods. Methods to measure BP. How will you measure BP? So step 1, preparing the patient. You have to prepare the patient. So the patient should be seated. So this is some of the examiner, question for examiner. Patient has sitting position or lying position or so preferably in the sitting position. BP should be checked preferably in the sitting position. Whenever the patient is able to sit, you have to make the patient sit. In some cases, CVS மாதிரி patient உட்கார முடியாது அப்படின்னா you can make the patient in lying. Okay. So next, the patient should be comfortable. He should not be anxious. So making comfortable. So his bladder should be free. Next, the patient should not have caffeine, exercise or smoking in last 30 minutes. Last 30 minutes la the patient idum pannirukuraru. Okay. So this is how you will prepare the patient. So next, you have to tie the cuff. Okay. So tying the cuff. So where will you tie the cuff? The arm, which should be supported. Arm should be supported in a table or a chair. It should be supported. It should be bare. Dress mala kattakoodadhu. And it should be tied at heart level. The cuff should be tied at heart level. Okay. Then next important thing is use appropriate size. use appropriate size. சைல்டுக்கு இன்ஃபன்ட்டுக்கு ஒரு சைஸ் இருக்குது, சில்ட்ரனுக்கு ஒரு சைஸ் இருக்குது, அடலசன்ஸ்க்கு ஒரு சைஸ் இருக்குது, அடல்ட்டுக்கு ஒரு சைஸ் இருக்குது, ஆம்ல கட்டணும் ஒரு சைஸ் இருக்குது, லெக்ல கட்டணும் ஒரு சைஸ் இருக்குது. ஸோ யூஸ் அப்ராப்ரியேட் சைஸ். ஓகே, இட் ஷுட் கவர் தி whole circumference. It should cover the whole circumference and 40 to 50% of your arm. Okay, at least 40 to 50% of your arm, and tie in such a way that it should be at least some 3 to 5 centimeters above your cubital fossa. Your lower edge of the cuff should be 3 to 5 centimeters above your cubital fossa. Okay, so after tying the cuff, we will so that is a technique. So first palpatory method and auscultatory method. Okay, palpatory method and auscultatory method. First என்ன பண்ணுவோம், கஃப் பண்ணியாச்சு. So we'll feel your radial pulse. கஃபை கொஞ்சமா inflate பண்ணுவோம். So at one point what happen, your radial pulse will disappear. You will mark this point. Tell me it is around 120. Okay, 120 la your radial pulse has disappeared. So what happens, then you will inflate the cuff for plus 20 to 30 millimeter of mercury, 20 to 30 millimeter of mercury. You will inflate, and then you will keep your, this is palpatory method. So after doing palpatory method, you have to go for auscultatory method. In auscultatory method, you will keep your stethoscope. You will keep your bella diaphragm. Bella is diaphragm. Diaphragm. Okay, you will keep your diaphragm of the steth over medial part of cubital fossa, where there is your brachial artery. Middle part of cubital fossa, and you will slowly deflate. What happens? We have already recorded a point where your radial pulse will disappear. Almost around this 120. What happens? There will be a start of your Korsakoff sound. Okay, it will be a start of your Korsakoff sound. And there are some 5 phases of Korsakoff sound, which no one can differentiate. Sound எப்போ ஆரம்பிக்குதோ எப்போ முடியுதோ அது வரைக்கும் ஒரே மாதிரி தான் இருக்கும். But some have told that it will be some thud like, it will be some whistle like, it will be some blowing like. But I have never experienced that. So Korsakoff sound, 5 phases. And at one point, what happens? It will disappear. It will just disappear at 70. So 70 millimeter of mercury. So this will mark your diastole. So Korsakoff sound appearance. So systolic BP is nothing but appearance of Korsakoff sound, and diastolic BP is nothing but your disappearance of your Korsakoff sound. Okay. So after this, what you have to do? You have to check in the next arm. Upper arm la paatha piragu next arm layum check pannuvom. Idhe mari again. Okay. So you should use the higher value. Endha arm la higher value vandirukko adha use pannu. For example, right side upper limb la 120/80, whereas left side upper limb la 110/80 na you have to prefer this value. Okay, you have to prefer this value. Okay, so then next repeat after 2 to 3 minutes. Repeat after 2 to 3 minutes. If it is a CVS case na, or the other system na 2 limb mattu podum. If it is CVS case, all 4 limbs has to be recorded. Normally your lower limb BP is more than that of upper limb BP by less than or equal to 20 millimeter of mercury. If it exceeds more than 20 millimeter of mercury, we call it a Fields sign, which was once the sign of AR. but no more it is considered as a sign of AR. It has been removed. Hill sign was once considered as a sign of AR. Okay. Then you have to document. You have to document the average reading. Average of two readings. Okay. The average of two readings. First reading and second reading, which is repeated after 2 to 3 minutes. In case the patient is in atrial fibrillation, it's better to get a minimum 3 readings. To get a better minimum of 3 readings. Okay. So, as we all know, normal BP is around 120/80. So again, moving on to the clinical aspects. Clinical aspects of blood pressure. Aspects of the blood pressure. Hypertension. So when you call it as hypertension, our American Heart Association has given a criteria to decide hypertension. Earlier it was told us pre-hypertension, late hypertension, early hypertension, late hypertension. இந்த மாதிரி நிறைய criteria இருந்துச்சு. So it was all closed, and now there are 4 stages. Okay, one, it is normal BP. 2, it is elevated BP. 3, it is stage 1 hypertension. 4, it is stage 2 hypertension. Okay, stage 2 hypertension. The normal BP 120, and it should be less than 120 and should be less than 80. So okay, if your systolic BP is raised, it is around 120/89, and if your diastolic BP is still remaining at 80, we will call it as a elevated BP. If your systolic BP is around 130 to 139, or the systolic BP is normal, the diastolic BP of around 80 to 89, you will call it as a stage 1 hypertension. If your systolic BP is more than 140, more than or equal to 140, or if the diastolic BP is more than or equal to 90, it is called as stage 2 hypertension. So consider the patient is having BP of 150, systolic BP of 150, and diastolic BP of 88. In the class la patient varum. It is elevated, or it is stage 1, or it is stage 2. Anyone? The patient is having systolic BP of 150 and a diastolic BP of 88. Yeah, it is stage 2 because it is R. It should meet any one. It should meet any one. Similarly, the patient is having systolic BP of 120, whereas the patient diastolic BP is 90. Where do this come? Is normal or elevated or stage 1 or stage 2? Yeah, it is again stage 2 because it should, even if it meet any one of the criteria to call the stage 1 or stage 2 hypertension, it should meet any systolic BP or diastolic BP like either one, and you should go for preferably higher one. Okay. Since the BP is around 120 now, you can't stay the patient in this stage 1. Either higher or other number, we have to give preference. Okay. So this is all about diagnosis of hypertension. So causes of some cause of hypertension. And most common cause of hypertension is idiopathy. Very essential, are also called as primary hypertension. This is usually seen in some middle age. It is middle age in onset. Okay. To call it as an essential hypertension, the secondary causes has to be ruled out. What are the secondary causes of hypertension? To call it as a primary hypertension or essential hypertension, the secondary causes has to be ruled out. So, your renal cause, all this glomerulonephritis, where CKD, AKI, acute kidney injury, all this has to be ruled out. Your renal artery stenosis, all this has to be ruled out. Okay. So next, endocrine. Name some endocrine cause of hypertension. Yeah, good. Pheochromocytoma, your thyrotoxicosis, Cushing's, your adrenal abnormal excess, all this will have then some other causes like metabolic syndrome, your OSA, all this can cause hypertension. So to name a patient as the primary hypertension, all the secondary causes has to be ruled out, but that is not of much clinical importance. No matter the secondary hypertension and the primary hypertension, you're going to start the patient on antihypertensive. Just you have to treat the other causes also. That is why we have to evaluate the patient with hypertension. So okay. So actually, when I appeared for my medal exam, in my final year UG, 75%. My case was CVA. My case was CVA. It was a brainstem stroke, but most of the questions, around 50% of the 50 to 75% of the questions were concentrated in this hypertension. So examiners, all these old-fashioned examiners will prefer the basics. So you have to know about some other hypertension also. What is white coat hypertension? So what is white coat hypertension? So on seeing doctor or on recording BP alone, the patient will have raised BP. Otherwise, it is normal in home. Home. Okay. So what is masked hypertension? What is masked hypertension? No, masked hypertension is not reversible. Masked hypertension is something like this. The patient is in office. His BP is normal. But when he comes to home, BP is high. So this is something due to anxiety. So how we can diagnose this? With the help of ambulatory or 24-hour BP monitoring. Okay. So then there is another term called as paradoxical hypertension. So what differentiates a physician from other doctors? Treating hypertension is not a big deal. Or patient hypertension is not a big deal. But what is differentiating a physician from other doctors is this: physician should know all these paradoxes. Should know all these paradoxes and all these differential causes. So that is what make the physician great, and that's what made me love medicine. And medicine interest on the reason on this differential diagnosis and this paradoxes only. Okay. So what is paradoxical hypertension? Any idea what is this paradoxical hypertension? Yeah, I'll tell you. Patient is having a disease. Okay. So this patient is having hypertension also. We are treating this patient. With antihypertensive. What you will expect? You'll expect the BP to fall, but rather this will cause the BP to go up, BP to shoot up. So why this happens? This happens. Consider a patient with your renal artery stenosis. If you give AC inhibitor or ARBs for this patient, what happens? Actually, the patient is already RAS suppressed. So in the patient, AC ARB inhibitor will produce even more renin, and that will cause your BP to shoot up. So patient with renal artery stenosis receiving AC inhibitors or ARB will result in paradoxical hypertension. Then patient with pheochromocytoma. These are all examples of paradoxical hypertension. Okay. So paradoxical hypertension is nothing but a patient with a particular disease end up in hypertension. You will treat with some antihypertensive, and the patient will have raised BP rather than that of BP coming down. So one such example is the renal artery stenosis. In renal artery stenosis, if you give AC inhibitors, that is bilateral renal artery stenosis. If you give AC inhibitors or ARB, it will cause raised BP. Similarly, in pheochromocytoma, if you give beta blocker, it will cause raised BP because of uninhibited alpha action. So beta blockers are contraindicated in pheochromocytoma. Similarly, in patient with diabetic autonomic neuropathy, if you give beta blockers, the patient will have raised BP. Why? Diabetic patient, if you give beta blocker, the patients are more prone for hypoglycemia. So hypoglycemia will cause sympathetic activity. So again, alpha action, your uninhibited alpha action will produce raised BP. Okay, will produce raised BP. A good episode, good. So next, postural hypotension. Where postural hypotension or orthostatic hypotension. As the name tells, what is happening here? With a change in posture, your BP is coming down. That is a fall in BP. With change in posture. What posture? From sitting or lying to standing posture. How much it is reducing? Actually, this is normal phenomenon. Because of the venous pooling in the lower limb, this is normal phenomenon. We will call it as a postural hypertension. The BP, if your systolic BP falls by more than or equal to 20, and your diastolic BP falls by more than or equal to 10 after 2 to 5 minutes. So this patient will experience giddiness because of this drastic fall in BP. This patient will complain of will present to you with a giddiness on standing down from lying position. So some causes of postural hypotension can be due to two causes. Your autonomic failure or your volume depletion. So generally what happens when you go from sitting or lying position to a standing position, there will be venous pooling of the blood in the lower half of the body. So your body will try to compensate by increasing your sympathetic activity. Increased sympathetic activity to the blood vessel will cause constriction of the capillaries. And in turn will increase the venous return to the heart, and that will increase your BP. So this is something compensatory, and this compensating mechanism will try to keep this fall in BP around less than 20. But in case of an autonomic failure, this fall will be very high that it is good enough to produce a hypotension. So most common cause of autonomic failure is, any idea what is the most common cause of your autonomic failure? This is diabetes. Most common cause of autonomic failure is diabetes. Okay. Then other causes include this, Parkinson's, spinal cord trauma causing transection of the spinal cord, or amyloidosis, or deposition of the amyloid, the peripheral nerves, and your CKD, where your urea will be settling in your peripheral nerves and will cause your autonomic failure. Okay, and volume depletion or hypovolemia. So these are all causes of postural hypotension. Then coming to the fag end of the session, we are having hypertensive crisis. Okay, hypertensive crisis. So hypertensive crisis is nothing but a group of disorder with multiple spectrum. So broadly, we will classify it into three: your severe hypertension, or your accelerated hypertension. So actually, there is different opinion. Each book tell different things about this hypertensive crisis, and my class is based on the Braunwald 11th edition, which is the textbook of cardiology, which is the standard textbook of cardiology. Hypertensive urgency, and hypertensive emergency. Okay. So severe hypertension is nothing but the patient is having a BP of around 180/110 to less than or equal to 220/130 with no end organ damage. So severe hypertension, accelerated hypertension is nothing but a BP of more than 180/110 to 220/230 with no end organ damage. And hypertensive urgency is nothing but the patient is having BP of more than 220/130, but still there is no end organ damage. End organ damage you expect in which are the organ you will expect end organ damage? Heart. End organ damage in heart is nothing but your acute coronary syndrome, MI. Then in the brain in the form of your ICH, intracranial hemorrhage, your transient ischemic attacks, your hypertensive encephalopathy. Then in kidney, the kidney in the form of some renal hemorrhages. Okay. So these are all the end organ damage you will expect. So hypertensive emergency is nothing but BP of more than 220 to 130, 220/130 with your end organ damage. So if it is an end organ damage, we will call it as hypertensive emergency. BP with more than 220/130 with end organ damage, we will call it as hypertensive emergency. Without end organ damage, we will call it as hypertensive urgency. And without end organ damage with a BP of range of 180 to 220, you will call it as a severe hypertension or accelerated hypertension. So how to treat a hypertensive crisis? Hypertensive crisis has to be given utmost importance. And the patient should be admitted in ICU admission with the parenteral, preferably IV antihypertensive. Like your nitroglycerin, your nifedipine, your labetalol. Okay. So how to treat? How much to treat? With the target of reducing your mean arterial pressure by 25%, or bringing your BP from to 160 to 110 or 100. So why you should not reduce to normal BP? Yeah, normal BP kondrakodadu. The patient is presenting to a BP with a patient is presenting to you with a BP of 220. Yeah, the patient BP 120 kondrakodadu. Yeah, because if you drastically reduce the BP, the patient will be the patient's cerebral auto circulation. The patient's cerebral auto circulation, to all organs, of course, to your coronary auto circulation, your coronary auto regulation, your renal auto regulation, your cerebral auto regulation is all set for this mean arterial pressure of above 160. The mean arterial pressure of that level. So suddenly reduce panna will cause reduced perfusion. Reduced perfusion to organs, and in turn will cause ischemia. Will cause, and most commonly it is seen in brain. Most commonly it is seen in brain. Okay. So final point. Resistant hypertension. Resistant hypertension. What is resistant hypertension? Any idea what is resistant hypertension? Yeah. So not responding to more than 3 drugs. It is patient is uncontrolled by 3 drugs or controlled by 4 or more drugs. Controlled by 3 drugs or controlled by 4 or 3 drugs. This is the definition which is given in Brown 11th edition. So resistant hypertension is nothing but the BP is uncontrolled by 3 drugs or controlled by 4 or more drugs only. Of these 3 drugs, one should be diuretics. Okay. So this is definition of resistant hypertension. Commonly resistant hypertension is seen in chronic kidney disease or your renal cause of hypertension. So resistant hypertension is most commonly seen in CKD patients. Okay, yeah. 3 classes of drugs. Or 4 or more classes of drugs. Okay, good. And one more thing I have missed. What is isolated hypertension? Sorry, isolated systolic hypertension. Your systolic BP is more than 140, whereas your diastolic BP is normal. So this is normally seen in old age patient, and whether to treat or not, it depends on multiple factors, and patient's cardiovascular mortality, patient's cerebral mortality, morbidity. Adana we have to decide whether we have to treat this isolated systolic hypertension or not. Okay, so almost we have covered well the hypertension part also. So any doubts regarding blood pressure or hypertension? So I think we have covered well. We have covered much regarding the exam point of view and regarding the clinical point of view also. We have covered much. So any doubts? Yeah, good. Actually, today's participant was around some 49 to 50. Last year in our classes, we used to get a census of around 200.